time today. So hi everyone, thank you so much for joining us today. I'm Nicole, the Continuing Education Coordinator for the Collaborative for Accountability and Improvement. So please feel free to submit your questions into the chat or Q&A at any time. Dr. Myint will address all questions at the end of his presentation. I would now like to introduce today's speaker, Dr. Michael Myint, Chief Population Health Officer for UW Medicine. Dr. Myint is an infectious disease physician and epidemiologist at UW Medicine. In his role, his accountabilities include providing executive leadership and strategic guidance for the integration of population health and value-based care across UW Medicine. His passions include improving patient and population-centered value across the continuum of care with a lens through health equity and addressing social determinants of health. Dr. Myint graduated from Jefferson Medical College, completed his infectious disease fellowship at the University of Washington, and also received his MBA from the University of Washington. His experience includes expertise in informatics, quality management, high reliability, population health, and innovative payer models. Thank you so much for being here today, Dr. Myint. And with that, I will pass it off to you for today's presentation.
Thank you so much. Can you hear me okay?
Hear you perfectly.
Awesome. Well, thank you, everyone. It's a real privilege to be able to talk to this group. I guess my bio sounds to me kind of like a little bit. I hope it doesn't set expectations too high, but I really hope to start to bridge communications and resolutions programs that really help the individual person that suffers from harm from healthcare to population-based approaches where we look at broad populations, whether they be in certain arrangements that we have, but certainly ultimately to the communities that we serve at UW Medicine, and I know that all of the other organizations on this call serve according to our mission, vision, and values. So, a little bit about UW Medicine. So I work very closely with Tom Gallagher, and I've worked just as a little bit of additional parts to the bio is that I've had the privilege not just of training at the University of Washington for my infectious disease fellowship and getting my MBA here later, but I've worked with most of the other large healthcare organizations across the Puget Sound. And at every single one of them, I've had touch points with Tom Gallagher and the groups here working on communication and resolutions. And so I have understanding of that. And my prior roles included a VP of quality and patient safety, where I was accountable for our patient safety programs in a 5-hospital system. UW Medicine's mission is to improve the health of the public. So that's a full stop. That actually is. And then we have our vision in regards to incorporating the research parts and the educational parts. But UW Medicine, for those who don't know, hold on, it's not advancing. Oh, there we go. UW Medicine is, we have 4 hospitals within our system, 2 of which operate as a single campus. We also have the Fred Hutchinson Cancer Center within ours, Airlift Northwest. UW Physicians is our physician group. We have many value-based arrangements across the care continuum with other partners across the Puget Sound region here. We have educational programs that train medical students and residents and fellows over the WWAMI states, which are the northwestern United States, inclusive of Alaska, Wyoming, Idaho, and Montana. And so we have broad training programs throughout. So UW Medicine is a very large $4+ billion healthcare delivery system, education and research organization, which adds some complexity as we start to think about how every patient interacts with our system and how we do that with high reliability and high value across that care continuum. So today's journey through my talk, I'm hoping that I can talk about running patient safety programs and sort of my evolution and starting to think about that patient safety to starting to move towards system-based improvements and population health approaches to this. So I'll talk a little bit about my experience with communication resolution programs, but also try to think about how we can scale it throughout this talk into looking at population, how these types of programs can help us understand and address population-based harms. And start to look at, I'll go into a little bit of detail about population health and value-based care. Those terms oftentimes are used differently in different organizations. So I'll say how we at the UW Medicine sort of look at those terms, and then start to think about how do we scale this across. And at the end, a little bit ambitious, but I'll talk a little bit about sort of how can we think about healthcare, patient safety, high value approaches to healthcare under sort of a grand unification. How do we address every patient that we take care of, that N of 1? And then how do we scale that to the populations that we serve across different types of healthcare organizations like UW Medicine and our broad footprint in the Puget Sound. So I'm first going to start with a little bit of a personal story. And forgive me if I actually choke up. I actually just recently revisited this. This was years ago when I was VP of Quality and Patient Safety at a prior healthcare organization. And I just talked to the CMO of the campus that we worked on this project together. And we both got a little bit choked up talking about this. But this was my first. So I just had become the VP of Patient Safety at a different healthcare organization than UW Medicine. And we had a death of a child in the ED that was seen, sent home, came back very, very critically ill and died in the hospital. And this was brought up as a potential safety concern of, did we treat the patient correctly in the emergency room? And so, you know, we had worked with Tom and the Communication Resolution Program, our risk team and others, and really had embraced this concept. And this was my first case in helping our organization actually operationalize this. So our initial response was really working with the care teams, supporting the care teams and the family that experienced the death of their child, and really working to communicate very clearly with all of those different stakeholders across that continuum, both in the ED and the hospital, and then importantly the parents of that child. We did the patient safety and quality. We did the root cause analysis. We're very rigorous about this, engaged a lot of different stakeholders. And in our very first meeting with the patient and their family to both express, you know, our response to this case, say our great empathy and sympathy and supporting them. We did all of the holding the bills and everything, but they said, oh, the patient's wife did not want to talk to us. The husband did, and I talked to him on the phone, but he wanted to bring in a friend of theirs who was a pediatric critical care doctor at a local children's hospital in the state of Washington, because, you know, they wanted to understand. And so our first meeting had the CMO of the organization, myself, a few other members of our risk team and others, and we had the first conversation. In that first conversation, we really explained what we're doing in regards to the root cause analysis. We again said we want to support the family in every which way, that we would be transparent in all of the things that we were doing to make sure that the family understood if there were errors made, that we would be fully disclosing of this. And I would say that first meeting ended with kind of the way that I thought that it might, in the sense that we had communication, but I don't think we really had addressed all of the questions and concerns. We fast forward and we had a follow-up meeting with the family after we had completed our root cause analysis. We laid out everything that we had done, all the opportunities for improvement that we had, and how we were going to continue to improve this. Our risk managers have continued to talk about how we can make sure that the patients and the family were held whole for those things that we thought we could have done better. And at that meeting, the wife did come, and we did sort of have a lot more kind of sharing, a lot of just I think you know, shared emotion about what the patient and what the patient's family experienced, and then the road forward, where we said we would continue to stay in touch as we continued to evolve our programs, and they said that they wanted to be engaged in that process improvement work as a voice of the patient's family that are always part of our care team. The reason why I get a little bit verklempt about this is that this was over 10 years ago. I just met up with that chief medical officer again, and she told me that after all of this, that family decided to have their second child when wife became pregnant again at our facility that we went through all of this with. And just as a sort of holistic, as a physician myself, you know, I think that that's the power of communication and resolution programs, both on the standpoint of the patients and families that experience harm and continue to experience harm within our systems, but also on the care delivery side. Like, you know, this is 10 years later, over 10 years, and me and that chief medical officer shared the story, and she shared that follow-up with me, and I was like, wow, this is powerful. So I just want to emphasize that the communication resolution program is something near and dear to my heart. The principles around this, and I know I'm talking to this group, I don't need to tell you this, but you know, principled, comprehensive, systematic approaches to patients harmed requires transparency, analysis of the event with human factors, supporting the patient family and the care team, financial and non-financial resolutions for unreasonable care, education about options to address representation from the patients. This could include legal representation. In this case, it was their friend, their friend who was a subject matter expert in pediatric critical care, who really, the first meeting really pestered us questions. The last meeting, I will say that she said this was about as good of a process given what happened as she could say. And she said, I wish that my system did more of this kind of work. So again, just that even that other stakeholder that was brought in, that was a clinical expert, thought our process, at least intentionally, tried to answer the questions that the family and she had about the care. And then collaboration with other stakeholders, assessing CRP programs with metrics, and then each of those key steps, that initial response evaluation that I mentioned my experience with in this first case. And again, we had multiple cases following this up, but just to tell you that I again love this. And as my journey started to take me more towards population health approaches, what I started to become more accountable for was harm was happening throughout our populations that we cared for, and how those affected the populations that our healthcare systems started to take more accountability for, whether they be through value-based arrangements, whether they be through programmatic work with other stakeholders in the communities. The 50,000 claims settled in 2022 for $4.1 billion. I put that in the context of, in the United States, we spent $4.3 trillion on healthcare in 2022. So 0.1% sort of, went to this medical legal resolution. I hope those numbers are right through the NPDB. If not, please correct me. But the communication of resolutions offered significant benefit to those patients. And when I say N of one, it's those individual, the case I talked about, and their families. And as we start to step back a little bit and say, how do we spread and share those real positive aspects to populations, we start to think about that difference between taking a population health view, right? The N of one patient versus the N of, let's say, King County, which is the county that UW Medicine is based out of. Seattle is based out of, 2.2 million plus people in this county. And this Norman Rockwellian view of healthcare as that individual patient getting a shot. The doctor in the back of this very famous Norman Rockwell, and he's about to give a shot to this kid who's staring at the degree, versus on the right, which was, you might see my wife actually giving vaccines somewhere in there. It's a picture that was taken on the mass vaccination clinics that we had for COVID. This was at Safeco Field where the Seahawks play. And we had this huge, massive clinic to do this on that population basis. And as we start to think of that N of one versus the N of many, the interventions we use might be different, but the principles might still be the same. And that's where I'll kind of go. Because as we all know, errors of commission versus omission, the act of commission or doing something wrong, and I know this is an oversimplification, versus omission, failure to do the right thing. And I'll just emphasize, this is from the AHRQ definitions on here. For example, failing to prescribe a proven medication with major benefits for an eligible patient is that error of omission. And it's commented in this AHRQ document that errors of omission are more difficult to recognize than errors of commission, but likely represent a larger problem. And that burns large in population health-based approaches. So what is population health, at least the way that we frame it at University of Washington Medicine? And what I'll say is that the broadest definition is the healthcare outcomes of groups of individuals, including the distribution of outcomes within the group. That's the highest level, generally accepted definition of pop health. But we said we needed to get, and that's very high level. We said at UW Medicine, let's get a functional definition of what we mean about population health approaches. So we define population health, building on that as a systematic approach to defining and achieving health and wellness outcomes for populations currently served and those that we wish to serve in the future from an equity and mission aligned lens. So we know that we're probably underserving certain patient populations, not intentionally, but due to structural, social determinant, and other issues. So we have that future-oriented lens on this, not just the population's internal. And we study and implement effective and efficient and effective models to optimize clinical value in patient and population-centered outcomes, net cost to deliver through a mission and health equity lens. And that would be inclusive of harm events and other things that occur within our health systems. I'll compare and contrast this with public health. Public health and population health, they definitely are related terms and sometimes used interchangeably I think, and sometimes it can get confusing. For our purposes, we'll describe public health intervention as those drivers of health for communities that are addressed primarily through governmental agencies. It's just our functional definition of this, but clean air, clean water, safety, gun safety, those kind of things tend to be more on the governmental basis rather than healthcare delivery organizations, although there's a Venn diagram overlap between those. So that's just how we define the difference between public health and population health. And we feel that healthcare delivery organizations definitely live more on the population health, although obviously we can be influential in many population health initiatives. And value-based care is sort of at the intersection of population health, you've seen in the sort of the yellow circle as defined by what I mentioned, and then value-based contracts, how we get paid. And that's kind of the majority of my job, is connecting the dots between these two. Where that intersection occurs is value-based care. And then as we look at a time frame, we hope to take on more value-based arrangements as opposed to fee-for-service arrangements in the future, so that we're aligned with outcomes. So we're paid for outcomes for patients, which help us to execute to our mission. So that's how we define value-based care, as that intersection between. And this group probably doesn't need to hear this anymore. We're probably very well aware that in the US, we spend more per capita than any OECD country, the Organization of Economic Cooperation and Development. These are sort of the other developed economies in the world. You can see on the left there. And in general, for the other OECD countries, there's actually a regression curve that you can see. The more you spend per capita, the better your outcomes. And this is life expectancy of one. But you can look infant mortality, maternal mortality, perinatal. They all sort of show that same, the more you spend. The only real kind of outlier is the US, where we spend a heck of a lot more, but really kind of fall midland to low compared with other OECD countries here in regards to health outcomes. Now, this graph is a little bit misleading. That's why I talked about public health. If you actually normalize for public health expenditures, that those organizations on the right move over to the left if you include public health expenditures, because they don't spend just on healthcare, they spend on prevention measures and other things. That moves a little bit closer. We're still not a great performer, but the numbers start to line up. And we're talking really huge numbers, as I already alluded to. The $4.3 trillion makes US healthcare, just what we spend on healthcare, if that was a country in and of itself, compared with the GDP, the total goods and output inclusive of healthcare. So the 4.3 trillion is a subset of the 26 trillion that's the US economy in 2022. The US healthcare budget would be the third or fourth largest country in the world just itself. And I contrast with number 5, India, 1.4, over 1.4, almost 1.5 billion people, the entire goods and services inclusive of healthcare of 1.4 billion people. We spend more on just healthcare for our country, and yet our results don't match up with other countries. And the way that my day job works is that we work across different payment models, fee for service on the left, that's the purple bar, moving towards what we would say is the sort of the highest value-based payment model, full capitation, where the organization takes the risk, gets paid a per member per month, and then is incentivized to do highly efficient, effective care. And the way that you optimize each of these models, in fee for service, you do a lot of volume. That's how you optimize the business model there. And then as you move across, you use different kinds of tools. And most healthcare organizations, certainly UW Medicine, we live in many of these, if not all of these. The only one we don't really have is full cap contracts, but we live all across this in a stochastic model, and we're trying to move the bulk of these towards the right, but it's not easy. The matching the fee for service and fee for value and trying to find success in a blended model is not easy. That's why in the US, we've had challenges, despite all the money we spend, in regards to delivering great health outcomes equitably across all our populations. So how do we measure what matters, right? In population health and value-based care, the old model of fee for service is, this Pac-Man and WRVUs and DRGs, right? DRGs for hospitals, WRVUs for everything else. Those are the currency of exchange as you move through. But I will posit here that those aren't particularly patient-centered. WRVU, I don't know any patient that I've ever cared for that cares what DRG they were in or what WRVU they're in. They hope that we have their backs, we communicate clearly with them, we diagnose and execute to what we need to do to keep them healthy, and we help work with them all around a particular event or be their lifetime partners in healthy living as we go through. These other measures, I would argue, are the least patient-centered measures that we have. And again, part of the challenging in moving from a fee-for-service to fee-for-value. So we posit this, and I'll just kind of jump ahead here, that really this is around the IHI, AAA, Michael Porter, the Harvard Business School, Utah. They all talk about clinical value as really that high level currency, real currency that we need to look at, which is the highest quality care and broadly defined. I would say patient-centered health outcomes or community-centered health outcomes, plus patients or communities experience over the net cost to deliver. And that's what we need to optimize across our care delivery for all of those folks that each of our healthcare organizations serve. We can further break down quality into different parts of things in regards to what we can do, and we call these value levers within UW Medicine, and work on this, because optimizing clinical value is really that kind of marathon, right? And you can't just train on lung capacity, or you can't just train on your legs, you can't just train on sort of your cadence and gait and all of those. You need to put it all together, and that's why we break it down into these value levers, so that we can build the right capacity and cross-train, so that at the end of the day, our organization, UW Medicine, is really continuing to execute to our mission to improve the health of the public. So clinical value as this grand unifier, as the currency that's more relevant to patients' communities than WRVUs or DRGs, I think it can be applied for both. I think on the N of 1, on the individual patient scale, but also we can look at populations and what makes populations healthy. Like I mentioned, this life expectancy, clinical value, decreased patient harm, that affects quality, experience, and cost, right? As we start to look at CRP programs, and CRP programs appropriately are focused on that N equals 1, where harm is identified. But as we start to think about populational approaches and populations that are harmed by especially errors of omission, things that we're not doing to keep people healthy and help them live their fullest lives, we start to think about this concept. And in physics, the grand unification theory is that originally, before the Big Bang, all these forces were together and then separated. And understanding these and understanding how they work together help us understand physics and the physics of the universe. I think that clinical value helps us understand how we can execute to high quality, high value care across. And healthcare is really concentrated here in the United States. The 1% of our population uses 22% of the expenditures of healthcare for a lot of reasons. I'm not going to say right or wrong in there, but other countries don't have this concentration at the highest level. If you just look at the top 5%, we're talking really 50% of all healthcare is driven just by the 5% of our populations. And I also show the converse of that. The bottom 50%, only 3% of current US healthcare expenditures go to 50% of our populations. And that includes things that help to keep people well, screening for high blood pressure, diabetes, healthy diet, healthy eating. Only 3% of our health care. And again, I'll blend a little bit of what we spend in regards to public health and population health, but we really do have a very concentrated healthcare system. And where does harm occur? I would say that errors of commission, things that we do wrong for patients, tend to be concentrated in those highest groups, right? Our hospitals and others, at least those that we observe, and can demonstrate harm. There's obviously minor harm that happens across other areas, like in the ambulatory setting of maybe giving a wrong drug, having a minor side effect and those things. But that's sort of that middle population. But I would say that in the this 50% of the population that only gets 3% from a cost perspective, there's probably a lot of errors of omission, and that's what I will try to demonstrate. And as we look at these kind of high acuity patients on the top of the acuity pyramid and those lower, I would say that patient safety, a lot of that gets focused on those highest end hospitals and those areas, whereas health equity, another lens that we can look at harm, really starts to look at those lower risk patients or lower utilizing patients, not because they don't need that, those healthcare services, but because for a variety of reasons, we don't distribute it to them. And I would just bring the Martin Luther King quote: of all forms of inequality, injustice in healthcare is the most shocking and inhumane, because it prevents people from living their fullest lives and living their most productive lives. How is this healthcare equity? How do we look at this? Well, this is actually my home zip code here. But the average age where I live is 86.9% here. If you look at King County, it's 82. So I live a little 4.5 years longer than the average person in my county. Actually, in my state, I'm living, people in my zip code live, over 6 years longer. And if you look at the United States, 10 years longer. But geography is destiny. The Dartmouth team showed us this long time ago. This is a map of King County in the Puget Sound. And I don't know, can you see my arrow when I'm pointing with my pointer on here, or does that not show up?
I cannot see it at the moment.
Okay, sorry. Well, King County is in the yellow areas with the longer 82 to 85, as I mentioned. But you can see geographically as you go further south, especially in South King County, that there's a significant decrease in how long people will live just based on geography, right? Geography is destiny in many ways in population health. And what I would say is that we're failing not just overall, but we're failing at an increasing rate. This is a graph over the course of years. And again, I'm comparing with the other OECD, mostly economically developed countries. That's that gray bar on top. And you can see that COVID, right, 2019, 2020, all of the OECD countries dropped a little bit in regards to life expectancy because of the COVID pandemic. But you can see that in 2022, they're mostly recovering. Whereas here in the United States, not only do we see a more significant dip in 2020 and 21, but we're continuing to see accelerating dip way out of proportion. So you can see that, that 76.1 compared with the OECD average of 82. This is the United States writ large, over 350 million people on average. We are actually losing some of the measures that are true population health-based measures, like life expectancy. We're doing a lot worse in it, and I would argue that that is harm for our patients and communities. And that harm is actually not evenly spread across all Americans equally, and that's not a shock to this group. This is a little bit of a busy slide, but I only will point out that the decrease is across all groups in the United States, at least those that are identified here by race and ethnicity. And if you show that the overall, which is the orange, the average lifespan between 2019 and 2021 dropped 2.7 years for white citizens of the United States, it went down 2.4, so a little bit less. But if you're Black, you lost 4 years of average lifespan. And if you were Native American or American Native or Alaska Indigenous, you drop 6.6 years of lifespan, starting from a much lower place. You drop a lot more. If you look at these years differences, and Asians dropped a little bit, Hispanics dropped significant 4.2 years, it's unequally distributed. And if you look at the cause of death, and I'll just look at the column here from a Kaiser Family Foundation study, in 2019, between 2021, deaths by homicides among Black and African Americans is the number 7 leading cause of death for that group, not in any of the other race or ethnicity categories. So a lot of inequitable parts of what leads to these health outcomes. And if I like to think in terms of value streams around prevention, early detection, treatment, management, resolution, as we think of how healthcare systems optimize health for our patients, let's just take diabetes or high blood pressure and heart disease. We can start to look at those things that we want to have in place, address social determinants, diet, exercise, things like that, prevention, smoking cessation, et cetera, all the way through disease management. And if we look at the potential harm of omission and commission, like I mentioned early on in the left there's going to be a lot of errors of omission. And then as you start to get to the treatment, those errors of commission hit in that the communications and resolution programs take, focus on. But I think there's a lot of opportunities across as we look at true harm. And I'll sort of kind of start to bring this back around and then open up for questions here. But the way that we frame this, and I showed the slide before, but I'm going to modify it a little bit. I'm going to put it in population-based terms. So this is the Taylor's version and Taylor Swift albums. This is the population health version now of sort of CRP. And I look at this as communications, and not resolution, but maybe reconciliation and improvement programs, right? So this is the population principled, comprehensive, systemic approach to populations harmed by commission and omission. This requires transparency, analysis of the event with social factors, those things that might be more on public health, but we need to call those out, identify them, and say what we can and can't do, certainly from a healthcare delivery perspective. Support communities and the care teams that care for those communities in addition to supporting the individual patients and families. Financial and non-financial resolution to close these gaps, these systemic gaps, these social determinant gaps that prevent some populations from living full and healthy lives, and educating options to address representation for these communities in healthcare delivery, collaboration with other stakeholders, assessing these kind of population-based CRP with metrics are going to be important. And then key steps, you can't resolve these issues easily, certainly. These are things that have happened over the course of US healthcare, and there are economic, social, and many, many other issues. But I would say that the key steps are ongoing response, that we continue to have these conversations, both on the N of one and N of our population level, and evaluation and improvement of interventions that we do in real partnerships with communities, right? This community engagement and resolution are so, so important for looking at population-based harm and post-harm systemization of lessons learned. How can we share with other organizations and aligned groups for the populations that we all serve together? And it's complex when you start talking about things that drive things like lifespan, population health, social determinants of health issues. But healthcare definitely has a role in this, and we certainly have a role in identifying the harm that happens from patients through these social determinants, like being unhoused or having food insecurities or substance abuse, behavioral health issues, that there's not enough access for treatment and resolution of those conditions. And so I'll kind of end with some unifying approaches and some thoughts that I have around this. And again, this talk, at first, I was going to talk more about what we're doing in population health and value-based care. But as I started to look at what this group really is and my experience with it, I started to reflect that this is really kind of where my mind goes with where we, at least in healthcare delivery organizations or those that take care of populations, how do we start to unify our approaches? And I say that it's multifaceted, multi-stakeholder. I think payment reforms are something that are really important. I think getting paid just to do stuff to patients, healthcare delivery or sick care, maybe leads to potentially errors of commission, sometimes patient harm from overtreatment. And again, we tend to concentrate healthcare here in the United States, as I've showed before. So I think payment reforms to help improve health of public is really important part of this, but also governmental reforms, public health, increased public health and safety, gun violence, those deaths from homicide, definitely have huge public health. Government has to be a big part of helping to address those, as well as deaths of despair through suicide, drug overdoses, and others. But healthcare definitely has a piece of that. I think population health approaches, interventions that address the health of populations, blood pressure management across large populations, diabetic screening, and appropriate treatment and prevention, tobacco cessation, other things, population health approaches, and then addressing systemic biases in healthcare. A lot of the DEI work that we do at UW Medicine are very committed to are going to be really important in helping to address systemic biases, but those aren't going to be easy. Those will take a long time to really start to equalize at the population level. And then again, our healthcare systems to enhance value-based care delivery, looking at that clinical value equation as maybe the true north, as opposed to some of the other measures that we have of productivity, and identify and help social determinants of health, address and minimize harm through CRP type programs. So, in this, I hope that maybe I made an argument that, one, CRP programs are key and critical to addressing patient harms. No question about that. And like I said, I feel very committed to those, and supporting that. And then how do we start to look at population-based harm in a different way, use same principles, but then start to think of how we can scale and both address the harms that happen at the N of one level, and then start to also use those same principles to address what I view as harm from this health equity perspective at the N of larger populations, like the populations that UW Medicine serves. And we're working very closely with all aspects of our healthcare system, including our health equity groups, to try to make systemic improvements and then look for long-term partnerships to do this better with our public and non-public entities. Again, UW Medicine is a state entity, so we have a little bit of a unique thing, but I've worked with all the not-for-profit healthcare organizations, all the major ones here in Washington State, and I think that there's a lot we can do together. So I'll end there and see if there's any questions, but Nicole, I'll hand back to you, and Thanks everyone for giving me a chance to sort of frame my thoughts and share them with this group.
Yes, thank you so much, Dr. Myint. That was a fascinating presentation. You really have me thinking about potentially how CRP can be adopted for more of a group approach. And I'm thinking about how that might work for some of the historically marginalized patient populations. And I don't have a question there. I'm just really thinking at the moment. But I do want to open up to our audience. If they have any questions that they'd like to ask, you can set them in, you can enter them into the chat or put them in the Q&A. We'd love to hear from you.
I'm not sure if I can see any of that, Nicole, so.
I'll let you know as they come in. Nothing has come in yet. I guess one question that I'll ask while we wait for people to type in. When you were sharing your story at the beginning about the child, you mentioned sharing lessons learned. Do you share lessons like within UW? Have you had success and experience sharing kind of lessons learned with the broader healthcare community?
So I recently rejoined UW. I trained here 20 years ago in my ID fellowship, but like I mentioned, I worked at several outside organizations throughout mostly the Puget Sound, but in the state of Washington here for other healthcare systems. I just had unique opportunities to do that. So my role here is Chief Population Health. I work with the folks who do patient safety work, like our chief medical officer, chief quality officers. But truthfully, I don't know enough about the details of what we're doing currently at the UW in regards to our N of 1 communication resolution program. So I can't answer that. Maybe people on the call might, but I don't have as direct insight into that. I know that from my prior experience, that was incredibly powerful, and I know because we did multiple events after that one that I highlighted, but some patients and families really engage in that, some really don't, and so I think that concept around improvement and then hearing the voice of the patient, I think especially for our care teams, I think is potentially incredibly powerful for healthcare systems. I usually go right up to the time, and I'm a fast talker. I actually very purposefully did this, and I thought I was going to talk a lot slower. My practice thing was 45 minutes here, but clearly I end up talking faster when I actually go through. So, I hope that folks, at least maybe maybe trigger some thoughts in folks around how do we scale up. But I guess I see a chat message coming in.
I can read out the questions so everyone on the audience can hear as well. So Natalie asked, what population-based solutions do you suggest delivering healthcare in different spaces like schools?
So, I would say that there are so many different potential interventions that we can do. I think that historically, one of the big things that I work on to get over, even in my own head, is sort of physician-based episodic healthcare. That's still ingrained in the way I was trained, the way I practice in private practice. As I was doing, I did consultative infectious disease as well as primary care for HIV positive patients. And I'll just say my own personal failing in that I used to think and believe that if a patient didn't show up, that was a non-compliant patient and their fault, not my fault, or I didn't have as much stake in owning that. And I own up to that early on in my career. As I started to understand more about social determinants and the barriers that my patients had in regards to getting care, their second and third jobs that they had to take off because my clinic was between 9 and 4 p.m. I sort of kicked myself just in the sense that I used to, sort of say that my non-compliant patient, it's kind of on them. Understanding more of these social determinants of health, and that's my personal journey as a care provider. And part of why I do what I do now is helping to systematize, although I still do a little bit of clinical care because I love doing clinical care at Harborview, my general infectious disease clinic. But these interventions that I think, so again, getting past that episodic physician-centered way of delivering care, I completely agree with what you mentioned, which is delivering in healthcare in different areas. There's sort of church-based EMT-based local delivery of care, schools, churches. There's a lot of community health centers. We really need to start thinking about how we address the geographic inequity in healthcare. We tend to concentrate a lot in our of our high high cost care, the tertiary quaternary hospital-based care in our urban centers. And actually in Washington State, and I suspect through the rest of the country, our community hospitals are actually suffering that out of proportion, and many are closing here. I do think we have to start thinking differently about how we do, especially health and wellness-based interventions. And I think schools are a great place to do it. I think churches, community centers, on reservations, different ways that cultural groups get together. In South King County, it's incredibly diverse, with Ukrainian and Hmong populations, and a lot of different ethnic groups that are there. And how can we start to ask community groups where are the best places to deliver that as a two-way conversation, as opposed to Mike Myint trying to think through where UW Medicine can do this. Just really engaging with our communities in an open forum. So I think there's a lot to unpack there. I also think that the ways we do this, especially now post-COVID, we have a lot of virtual ways that we can engage with patients, and behavioral health has shown a lot of value in being able to broaden the scope and reach of our behavioral health services through video conferencing. And that won't work for every patient and every condition, but I think for those appropriate ones, that's the population health approach. Let's use those and then reserve those spots for those that would benefit more from coming in person and doing others, because we have such an access challenge right now in a post-COVID healthcare delivery world.
We have another question from Liz, and she says, a fascinating discussion. How have you spread the message of your programs to your population or to the populations?
Very hard. One of the biggest challenges, from my opinion, is that, and that's why we built in our support of our mission, those populations that we care for and that we plan on caring for. And let me give you an example, a very concrete example. We looked at the outcome differences of breast cancer screening in those patients who are Black and African American women for breast cancer screening that we cared for within our system. And we showed that patients who saw us for primary care that were Black and African American got screened at a lower rate and had worse health outcomes, had more mortality and morbidity with their breast cancer. So we did very specific outreach programs for those patients in our system. But what we heard from our community is that many of communities that we wish to serve don't have a lot of faith in not only UW Medicine, but other healthcare systems. So they're not in our database, they're not in our denominator. So even though we've improved significantly breast cancer screening rates and are starting to see some outcome differences in our populations, we're still missing those patients that are outside of our kind of traditional healthcare delivery system and paneled to our primary care or see our specialist. And so I think that the sharing the message is really that two-way communication. It's really going out and listening more than telling. And at academic health organizations, we have a lot of really smart people who study this. And I think that we do need to listen in a different way and outreach to organizations that traditionally perhaps have historic bias, other reasons why they don't necessarily trust us or other healthcare delivery systems. And really start to meet where I think we can have meaningful conversations. It's really hard. University of Washington Medicine, we lost $150 million in 2022, and if it wasn't for FEMA funding and other things, we would be even a bigger hole with harder access than what we have now. But I do think that it doesn't cost a ton to do that. But I also think that if you're going to go out and listen, you better be ready to do something about it. And that's been some of the challenges that I think healthcare delivery systems have had. We're sometimes scared about asking about social determinants. Are you unhoused? Do you have food insecurity? Partially because we don't have an answer to that. But I think that's that sort of almost paternalistic view that if we ask the question, we have to be the one to be able to do something about it. And I've always said in my clinical practice that if I ask that and I find out, it's just going to help me from my medical from the medical side understand the patient's situation better. And so I think we shouldn't have that. We need to be able to solve it right away. And that asking the question is also part of understanding the challenges and problems and the needs of the communities and the individuals. And so I think we just have to listen differently, and we have to actively outreach to communities that historically we clearly are underserving. And the numbers I showed you, especially for Native Americans and Alaskan Natives, like that life expectancy difference is just, I'd say, unconscionable, especially given our history in I think not resourcing many of the displaced populations that have happened over time. So I think that it's really an understanding and not being afraid to ask these questions, even if we don't have direct answers to them.
Are there any other questions for today?
Hopefully there's a little bit of thought. Please feel free to reach out to me. Nicole and Tom and others have my contact information. I'd love if any of the folks on the call, I can't see everybody, any faces or anything, but if your organizations are interested in helping to try to understand and address these issues of harm at the population basis and health equity, love to partner with you. We really are committed to health equity and are trying to figure out ways that we can continue to accelerate this work and then create sustainable financial models for healthcare organizations to really lean in for this harm that's clearly happening to our populations and start to bend that life expectancy curve back up to where I think the richest country in the world needs to be to serve all of our citizens to live full and healthy and productive lives.
Well, if you'd like to connect with Dr. Myint, please feel free to send me an email and I'd be happy to connect you. Also, we'll post the webinar on our YouTube channel in a week or so, so please feel free to share with your colleagues or anyone who might be interested in this discussion as well. So with that, thank you everyone for joining us today, and we'll see you next time.
Thank you so much.
Hey everyone.